to pick up on ethical and legal issues part 2. There was another question about the order of the PowerPoints, if you want to know, to kind of know ahead of time. After that, we're going to start depression, as we had talked about. Then we will go to schizophrenia. Okay. Personality disorders. Obsessive compulsive disorders. Eating disorders. And last, neurocognitive disorders or dementia, delirium, Alzheimer's. Okay? That way you'll know ahead of time. Okay, let's see if I have any other questions. Okay. So you're having problems with the math problem, and I did see that Miss Hyde is going to give you some help, so that's nice. Those pediatric math problems can be a little bit challenging, can't they? All right. Is there any other questions that you have for me right now? All righty. Sorry, I'm getting crackers out between my teeth here. My quick lunch. Okay, well, we'll go ahead and get started. I will start recording and I'll share my screen with you. Okie doke. So when we look at commitment, we have voluntary commitment admissions and we have involuntary commitments. The good news is most people voluntarily commit themselves, with encouragement from their family, loved ones, those folks. So most people voluntarily go into the psychiatric unit on their own. But just a little statistic is 1 million people are admitted to healthcare facilities for psychiatric treatment each year, okay? But good news is 2/3 are considered voluntary. So they realize they have an issue and they seek help, which is encouraging. So for a voluntary, that's where the person basically asks to be admitted to the institution, and they can stay as long as treatment is deemed necessary. And the thing with voluntary is they have the option where they can voluntarily leave also. So they can sign themselves out at any time. However, once they are admitted to the psychiatric unit, before they can just walk out, they have to have a mental status exam. So they have to be checked out by the healthcare professional, the psychiatrist, the psychiatric nurse practitioner, to make sure that they're not harmful, that they're not a risk of harming themselves or anyone else, is the big factor, whether they can leave. Okay. If it's determined that no, they need more treatment, they feel the healthcare provider feels like, they may hurt themselves or someone else, they're just not ready to go out, they might end up being changed from a voluntary to an involuntary if they're insisting on leaving. Okay. But hopefully, that they can talk to them. Most of the time they can talk to them and say, no, you're not ready to go. We need you to stay through the weekend, that kind of thing. Involuntary, of course, when someone's involuntarily committed, they lose a lot of their individual rights. You know, we talked about all those rights we want to adhere to. We want to, you know, let them, you know, have their autonomy. But again, with involuntary, it's determined that they need to be admitted. So there's different reasons for involuntary commitments. The first one is the emergency commitment. And this is where the person is exhibiting behavior that poses a risk to themselves or others. Okay. And this admission is usually brought about by relatives saying, you know, he's very dangerous to himself or threatening others. So it could be relatives, could be friends. And, you know, it's better if one is, you know, at risk for hurting himself or others, that, you know, a good friend will know that, hey, you know, you need to go get some help, so they don't hurt themselves or anyone else. And it also could be the police arrest them for their conduct. The court could be a court order or just another healthcare professional. They are time limited. Involuntary commitments are time limited. We can't just, you know, admit them forever and ever and ever. Typically, there is a court hearing for them, and that's usually scheduled within 72 hours. And then the court hears all the, you know, everything about the case and determines whether they can continue to be an involuntary committed person or if they can be discharged at this point. Is it deemed necessary? You know, the court's going to say, yes, you do need to be in the facility. And if they ask them, okay, you still need help, we can take you off the involuntary commitment if you voluntarily stay. Okay. But if they refuse that, you know, they say, no, I want out of here, I'm leaving, then they will be given an additional period of involuntary commitment. And then they'll be scheduled for another hearing, again, at a specified time, can be from 7 to 21 days, to determine again whether they still need treatment or can be discharged or, you know, switched over to a voluntary if they agree to stay. So all those factors will be looked at again. Another reason to involuntarily commit someone is if they are mentally ill, you know, they have a severe mental illness and they are needing treatment. One of the big things in psychiatric care is maintenance of their medications. They have, as Ms. Hyde probably hit on when she was talking about the medications, they have a lot of unfavorable side effects, unfortunately, that, you know, tends to make the people that need them not want to take the medications. But if they don't take the medications, then they get into some mental disorders, or their mental disorder exacerbates. So they really need the medication. So it's a really sad situation. But yeah, the side effects can make them non-compliant with that. So if someone hasn't been taking their medications and they are, you know, having a severe mental illness situation, exacerbation, and they can't make informed decisions for themselves, they're likely to cause harm to themselves or others, or they're unable to fulfill their own needs, you know, their basic personal needs for health and safety. So they can be involuntarily committed. I saw my little chat room flashing. Did somebody want to say something or ask something? Because I can't see the chat when I have the PowerPoints up. Everybody good? feel free to speak up if you need to. Any questions right now? Everybody sees my screen, correct?
Yes.
Great. Thank you, Tracy.
No problem.
Okay. So it could be that they need treatment, but they have a severe mental illness. Well, our severe mental illness patients typically are our bipolar patients and our schizophrenia. Schizophrenia, if I had to pick out one, that would be the worst. If they have a severe case of schizophrenia. Of course, we're going to talk more about that. But they can be really out of touch with reality, but also our bipolar disorder patients can also have that problem. Another way these people can have treatment is involuntary outpatient commitment. So that is court ordered. And this is a mechanism to keep that person with a severe mental illness seeing healthcare providers as often as they need to, so that they don't have an exacerbation of their symptoms, stop taking their medications. So these are folks that need to be monitored closely, and they won't voluntarily go to these outpatient visits. So the court says, okay, you can stay out of the hospital as long as you go in once a month, once every 2 weeks to the clinic. And sometimes it's to get their once a month medication injection. The Invega is a great IM injection, antipsychotic that can be given once a month. And that's great for our folks who are non-compliant. So that might be the case that they have to go in and get the injection. But anyway, the court has ordered that they have to be seen outpatient because they've had a history of not taking their medications and having exacerbations of their symptoms and then ending up being involuntarily hospitalized. These folks also without treatment will deteriorate, it's felt, to the point of requiring inpatient commitment. They have a severe and persistent mental illness like schizophrenia and bipolar are two examples. And another thing with some of these folks are they don't have an awareness that they have a problem. And we'll talk more about that. So, if you think you don't have a problem, you're not going to be taking your medication and you're not going to be seeking the health care that you need to manage your illness. So those are folks that would have this involuntary outpatient commitment. They have to have an individualized plan, treatment plan in place. And of course, a healthcare provider who has agreed to provide the treatment. So that's another example. Gravely disabled client. Okay. These folks are typically found out in the street, not in the street, so to speak, but out on the street. They're homeless. They're because of their mental illness, they're at danger for serious physical harm. Someone can hurt them. And they can't provide for their basic needs, food, clothing, shelter, medical care. So they're found and, typically the police are bringing them in to get them committed, okay? Because they're not using the available resources and also they're not, their personal safety is at risk. So they're so disabled by their mental illness that, for their safety, they need to be committed. At that point, a guardian will be assigned or a committee will be appointed by the court to ensure that they're managed, they're advocated for and they're looked out for until they can legally be restored to competency. if they can legally be restored to competency. And that, again, will take another court hearing. Okay, so that's our involuntary and voluntary commitment. Lawsuits and psychiatric nursing. Of course, we all want to avoid lawsuits. One problem can be that we've already kind of touched on is breach of confidentiality. And we had talked about that. And definitely in psychiatric care, it can be, very have a negative effect on that person's life. They can lose their job, their credibility in the community, as we already kind of hit on. So, of course, breach of confidentiality is where aspects of the client's case are revealed and or that the person's been hospitalized. So if someone would call to the unit, unless they have a secret password or however your facility handles that, we can't say, yes, they're here. Okay. I know I know from the VA, they have a telephone on the unit where family can call in. And, but as far as calling the nurse's desk and saying, is Mr. Smith there, Mr. John Smith there, we cannot say that. Again, it's facility dictated as how that's handled. But, just telling someone that someone's there can be detrimental, right? That can be detrimental to their job, unfortunately, because of the stigma with mental illness, and can be, cause harm. So if it's found that because of the breach of confidentiality, they suffered some sort of harm, then you could be charged with that. So we've got to be very careful with talking, about the person anywhere, and we don't do that with any of our patients because we could get in trouble for that for any of our patients. But, especially with mental illness, the stigma in the community is out there that it could cause someone to lose their job. Also, it could be defamation of character when you've shared information that's detrimental to the client's reputation, and that's a breach of confidentiality. Involves saying something malicious and false. And again, if it's found that they suffered harm because of what you said, then you could be charged with that. Libel is writing, and occasionally this arises out of critical judgment statements. So you've got to be so careful what we write in those charts, right? In the client's medical record. And that's why, again, which I've already hit on, and you've heard this before, that you just state the facts, right? Only the facts, objective data. And you have statements that back up that objective data, just factual statements. So if you write it, then that would be libel. If you say it and it's overheard, that would be slander. Okay. Invasion of privacy can result when a client is searched without probable cause. So I can't speak about LifeWorks, but I'm thinking they don't do it either because it's kind of gone. They don't do this. I know when you go into the prison system, they do. But as far as the psychiatric unit, most units don't really do that, don't search. But they can do a body search if that is what the protocol is at that particular facility. Need to have a doctor's order for that and have rationale, probable cause that you're worried about this person bringing in something that typically can hurt themselves or someone else. So like I said, most institutions are getting away from that, but that is a possibility that could be done. And if there's not probable cause, of course, you want to have a doctor's order. So it's on the doctor to decide whether there's probable cause. Other things, which you've heard these terms before, also assault. If you are threatening a patient and they are made to kind of be fearful or apprehensive that you're going to touch them without consent, you could be charged with assault. And battery is actually touching someone without their consent. So we want to always make sure we have permission to touch anyone or give them a treatment with their consent. So if a treatment is, for an example, is if a treatment is given to a patient and they say, no, I don't want, say, CPR, and they've got a DNR with them, you could, of course, be charged with battery. Treatment needs to be given permission for. If it's against their wishes, then, and it's not an emergency, then you could be charged with battery. And you don't even, harm does not, or injury does not have to have occurred for these charges to be legitimate. So again, we always, ask if it's okay if we check somebody's blood pressure even, or, I've got your medication. And, of course, there can be non-verbalized, permission, consent. If they hand out their arm, then we know that they're fine with that. Or we're giving them an IM injection and they lift up their sleeve, that's implied consent. So that's fine. And the last possible lawsuit is false imprisonment. And of course, this is confining someone against their wishes, and it's not an emergency. They're not threatening to hurt themselves or anyone else. And, some examples are, you just feel like they can't leave. Well, on a psychiatric unit, because that's what we're talking about, they would be reevaluated to see if they can leave. But we can't lock them in their room. Okay. But psychiatric units are a locked unit. So, they can wander around the unit and we'll get the doctor to come in and, do all that voluntary, involuntary commitment situation. Or taking their clothes away from them so they can't leave. Anyone who has a voluntary commitment has the right to leave, but of course they have to be checked out by the physician or healthcare provider, physician's assistant or nurse practitioner before they can leave. Okay. All right. Of course, we all want to avoid liability, right? We don't want anyone to sue us. So how can we avoid that? You want to be very attentive to your patient, right? You always want to practice having a good rapport with your patient, good interpersonal relationship with the patient and their family. To make, and typically if someone is treated well, things may happen where the patient's not very happy about it. But if long as we don't get defensive and, we're apologetic or whatever's required, but we're very, we're trying to maintain a good relationship with them, typically people won't sue. But of course, you have those people that I know, I don't know if you've run into this, but you're going to run into this where they write everything down. What's your name? And, what are you doing? And, those kind of people make us a little nervous. They're a little more suit prone. It looks like they're keeping track of everything. They're just watching for you to do something wrong, which makes us all nervous, but, or very critical or complaining or uncooperative, and may even be a little hostile. But the best thing we can do is, try to get a good relationship with them, develop a good relationship no matter what. Okay. Of course, the natural tendency is to get defensive and withdraw. I'm not going in there, but that will cause actually more of a more prone to, legal action. If you're doing what you're supposed to do and you're charting that you've gone in there every hour and, checking up on their pain relief and, being very attentive, typically they won't have justification to sue you. Okay. Okay. So again, natural response is becoming defensive, but it could increase your likelihood of a lawsuit if something negative happens, if something unfavorable happens. If you've had a good rapport with that patient and the family, they're a lot less likely to sue the hospital and you if there was a good rapport. So insensitivity to their complaints and failure to meet their needs, emotional needs, can influence whether or not a lawsuit is generated. So we don't want that to happen. So just really, really be accommodating for our patients, good rapport with them. Educating the patient, always telling them what's going on, educating them about any new medications. And the hospitals have, implemented that as far as like, okay, you first comes to mind Lovenox injection. You have to teach them about Lovenox, why they're getting it. So there's a lot of teaching in nursing and, educating our patients in psychiatric nursing on their medications, the side effects, their resources. Very important to keep that good rapport. Of course, you're always going to comply with the standard of care. And you're always also going to be supervising anyone working under you, your nursing assistants, your psych techs, whatever positions are underneath you or that you would be under your supervision. You want to make sure you follow up on anything that you have them do or any care that they're giving. Definitely adhering to the nursing process, documenting, we talked about, and evaluating anything, how was your anti-anxiety medication helpful? And we also have on the psych units, we have our patients rate their anxiety on a 0 being no anxiety and 10 being the worst anxiety, just like we do pain. So you want to reevaluate if they've been given something for anxiety, what would you rate your anxiety now? And typically those are given PRN for anxiety. So we definitely want to follow up, make sure that they've gotten relief. And if not, we're going to call the doctor and, see what we need to do to get them some relief. Okay. Alrighty. All right. Well, that finishes up the ethical and legal part 2. Okay. How do you protect yourself from assault and battery? Okay. Okay. First of all, let's see. Let me back up. I'll start at the top and go down. If they're given voluntary commitment only if they stay, then isn't that still involuntary? No. If they're given a voluntary commitment and they say that they will stay, or that, yeah, if they're, I think I'm understanding. Okay, if they're switched from involuntary to voluntary and stay, they're voluntarily staying. Okay, and again, you can't, and you have more rights, more privileges depending on the facility with a voluntary. Like your medications could be, related to that. If someone isn't taking their medications, they're probably going to be involuntary committed. But if they're voluntarily there, they know that voluntary means you go to the group therapies as your doctor has prescribed you to go to. You take your medications that the doctor's prescribed for you. So as long as you are adhering to the care given, the care that has been mapped out by the doctor, then you can be a voluntary. And again, you can't just leave, but you can advocate for yourself a little bit more so, because involuntary, you lose a lot of your freedom. Okay. And it depends on the unit also. Okay, when you're going through the slides, could you please help us? Kind of need to know info for the test, please. I kind of try to do that. I know Miss Hyde, I heard her say her little ditty. I can't remember what it was, but anyway, it's all important, but I do try to say, enunciate it for you as far as what you need to know. Definitely, I don't want to go back through and go through everything, but, if you have a question about, is this something I need to know? Hopefully I'm enunciating enough that you can tell what's important. But, it's not just this test that you need to know it for. It's the final you'll need to know it for. And then the big test, the NCLEX. So it's all really important, but all the different kinds of commitments, definitely, know the reasons people can, need to be involuntarily committed. That just comes to mind off the top of my head, but, I'm trying to think about the other material. I will give you a blueprint and hopefully that will give you a little more guidance. Okay. On that. How do you protect yourselves from assault and battery by our patient? Oh, okay. Well, just to speak on psych, there's a lot of protection that you just have to be really aware of your surroundings. Okay. And I know psych patients get a bad rap as far as, I'm scared to go to the unit because they're going to all attack me. And all my students, I would say, 99.9, there might be somebody who's fearful, but I know there's a fear of the unknown. But once you get on the unit, you understand that it's safe, and you look for, warning signs to get away. If somebody's starting to get agitated, we totally take ourselves out of the picture. We don't have to go in, right? You're just aware of your surroundings. You don't go into a patient's room. As a student, if you're going in there with the staff, but of course, even the staff will never back themselves in a corner in the room. Okay. They will have the door behind them and they will be able to exit if they need to. So always have an exit plan, an exit escape plan there. So you never want to get cornered in a room. All right. So always have an exit nearby. Let's see what else. Keep a safe distance, and we'll get report when we go on the units, and we'll know who we need to avoid. Okay. And I won't assign you anyone who's a potential danger. Okay. And you're aware of your surroundings. You're keeping a safe distance. Like I said, you're looking for things if they get to be a little bit, people are getting agitated, or there's something going on between a couple patients, we're not jumping in and saying, what's going on, right? That's not our job. And the staff are trained, of course, how to de-escalate those situations. So, you know, and the good thing about psych units are they are safety proof. Okay. They're safer than the med surge floors. Okay. If we had a psych patient on the med surge floor, that's where you would want to be more leery, actually, because, they're not allowed to have sharp objects, no pins, nothing hard. So their pencils and pens are flexible. Of course, no scissors, anything that can be considered used as a weapon are definitely kept out of their hands. At the VA, they've got a lot of neat safety factors as far as, I could show you, and I'm hoping to show you those. Again, I haven't been to the unit yet at LifeWorks, but I'm hoping to show you the safety features on the unit. But, like they don't have a shower head where they could hurt themselves. But of course, this is hurting themselves. But just being aware of your surroundings. For your psych rotation, you're not going to be doing any skills. Okay. You're just there to communicate with the patients. Therapeutic communication is our main goal for our rotation. Okay. So we're not giving any medications. I will have you go with the nurses and watch how they assess their patients. They'll ask everybody, do you have any thoughts of harming yourself or anyone else, if that's a factor? See what medications they're taking. So you're doing a lot of observation and communication. Okay. All right. Let's see what else. Okay. Question about defamation of character, if the information is true. Okay. If it's true, so you still, typically what we'd be charting is something that was said or done. We wouldn't really put anything about their mental illness. Okay. We would describe perhaps if their bipolar comes to mind, if they're acting out, if they're manic, in their manic phase, we would just describe what's going on. We wouldn't say they're very manic today. You know what I'm saying? You would just describe patient had jumped up on the table and was told to get off the table, that you can't stand on the table, and the patient adhered to the command. So I can't think of no, I mean, as long as you're just describing what's going on, stating the patient stated such and such, you're not going to be charged with that. It's when you say out and out, they're just acting crazy today, something that blatantly bluntly stating that kind of thing, or something like that. So, the chart has their diagnosis, but we really don't chart about their diagnosis. We just chart about what objective and subjective data, right? Objective, what we're seeing, their affect, and we'll talk more about that when we get depression. Their affect, their mood, their behavior, those kinds of things. Okay. All right. Does that help? Okay. Never turn your back to them either. Correct. Exactly. Never turn your back to them. Right. Thank you. Good point. Okay. Does anybody have any other questions? Thank you for asking those. Okay. All right. Okay. So next we're going to go through depression. What's our time? All right. We can get started on this. All right. All right. Why isn't it there? Shoot. Let me see if that brings it up. No, that's not what I want. Let's see if this does it. All right, I got to figure out. I think I'm going to have to pause it. So there's going to be two recordings for today. Darn it. Okay. Because I don't think I have it pulled up. Thought I did. Nope. Okay. All right. Oh, okay. Maybe I can work through this. Yeah. Sorry. You're hearing me talk through stuff here. Yay. Figured it out. Okay, so depression and suicide. Okay. All right. Minimize that. Minimize that. Maybe I can get to it next time. Okay. All right. Solve one problem and have another one. All right, let me stop my share. There we go. Okay. All righty. Now we can do it. Sorry, guys. Technical difficulties. Where is my stuff? Oh, darn it. No. Why isn't it showing up? All right, stop sharing. There we go. Oops, wait a minute. I think I have to hit share. Third time, fourth time's a charm. Okay, there we go. All right, can everybody see that?
Yes, we could see it, but it's not zoomed yet.
Yes, thank you. All righty. How's that?
Perfect.
Thank you. Okay, so depression and suicide. So depression is a mood and affect disorder, as is bipolar. So mood is when we define mood is like we ask someone, "How are you feeling?" Um, and so that is the subjective uh, statement by the patient when we say, "How are you feeling today?" And they say, "Oh, I feel great." Okay. Affect is what we observe. So we describe mood as affect frequently in psychiatric nursing. Okay. Because this is what we observe the patient as their behavior indicates. So if somebody says to you, "Oh, I'm great today," the nonverbal affect, what we're observing is they're not so great, right? They appear not happy. Okay. So that's what we typically document, their affect, what we observe, our objective read on their mood. Okay. So, and it's important that we recognize when it's unstable, like crying and rage, euphoria. We see that with our manic patients. Blunting is the same. I consider the same as flat affect. There's no emotion. Okay. And we also, as a psych nurse, you will want to, how are they functioning? Especially with depression. Our folks that come in severely depressed really don't have much energy. And so, they're to take a shower is a major ordeal. So typically their ADLs have been neglected when they come in. They don't solve problems very well. And that can, so their affect can be a determining assessment of how severe their mood disorder is. One term is euthymia that you'll hear when we go to the unit. And that euthymia is normal, okay? Normal, healthy fluctuations in mood. So they're not overly happy or overly sad. So they have normal happiness and sadness cycles. We all get down in the dumps a little bit. But we also have, where we're happy, but we're not overly happy. Okay, those would be our manic patients, you'll see. Depression is one of the oldest and still one of the most frequently diagnosed psychiatric illness. Again, feeling occasionally blue is common. We all have our blue day, but they're short-lived. They don't go on for 2 weeks, which is one of the criteria for determining someone has depressive disorder. Okay. So it becomes pathological when the person is unable to adapt, okay, to the stressors. They don't have an interest in their usual activities that they enjoy. They have sometimes somatic symptoms. They complain of aches and pains and stomach upset and headaches, and changes in appetite, either typically decreased, but they could have increased appetite, and their sleep pattern. They're either not sleeping well or wanting to sleep all the time. And these folks just see everything with a negative twist to it. So they really have a negative attitude. Okay, everything is terrible. Life is awful, those kinds of things. Okay. When we look at epidemiology, Depression is diagnosed more frequently in women. Okay. But when we look at men, they may be undiagnosed, underdiagnosed, because men tend to have, our culture, wants them to have that stiff upper lip. And so sometimes their depression, they mask it with alcohol abuse. Okay. So sometimes the thought is that they are underdiagnosed. But women are diagnosed more frequently. And it's more common also in lower socioeconomic classes. A national study found that depression was more prevalent, in whites than in blacks, but depression was more severe and persistent and disabling in blacks. Because they are less likely to be treated. Okay. So it's only because white people seek treatment more frequently than our African American culture. And they feel like that when they finally do get diagnosed, they have a lot more severe depression and they're much more disabled. It is higher in single people. Believe it or not, marriage can be a stressor, but as far as, and you're going to find that in all of these mental disorders, that marriage is a protection. It's higher, there are higher incidents of mental illness in single, divorced, widowed folks than there are married folks. So marriage does have a positive effect on our psychological well-being. And there is a higher incidence in the spring and fall of depression. Sorry, I'm trying to get my screen right here. All right. All right. Okay. So major depressive disorder, of course, is characterized by depressed mood, right? And affect. We're going to see these folks and they just, woe is me. Oh, you can just pick out the depressed people on the unit, definitely. They're just sluggish. If we can get them out of their room, a lot of times they just want to sleep all day long, and we can't hardly get them out of their room. Only, sometimes they'll only come out to eat. And they just, if they're out and about, they're just very sluggish looking. So you can really tell who the depressed people are typically. Some other criteria are that they don't have any interest or pleasure in the usual activities. They love to go to their family's house on Sunday for dinner, and they don't want to do that. They just don't want to do any of the things they normally really enjoy doing. They typically love going for a walk in the park. No, they don't feel like doing anything. So another criteria are, and you do need to remember this, I'll try to get better about pointing these out, that the symptoms have been present for at least 2 weeks. Okay, that is a definite criteria. Again, because, depression, we all have our days and maybe a few days, but if it goes on for 2 weeks, then that's a criteria that's indicating possibility of major depressive disorder. Also, that there's no history of manic behavior. Okay. Just kind of file that, because when we talk about bipolar, there is a bipolar 1, which is manic. Okay. Mostly. Okay. And then bipolar 2 is depression mostly. Okay. But we'll talk more about those. So a criteria is for major depressive disorder that they've never had any mania. Okay. And of course, we always want to rule out any substance that could be causing the depression or another medical condition, which we'll talk a little bit more about in a couple slides. But if you have the notes below, again, remember I talked about the DSM-5 and they have the criteria. So this helps us to diagnose, for example, major depressive disorder as opposed to depressive bipolar disorder. So the criteria is that there are 5 or more of the following. And if you can't see your notes, if you have your book, you want to open up to it, that's fine. On page 384 is the box 16.2 that talks about the criteria, DSM criteria for depression. So it's gone on for 2 weeks, and it's a change in their previous function, okay? You know, it's different than they usually are, okay? And one of the symptoms is either depressed mood or loss of interest or pleasure, okay? They're just not interested in doing the things they normally do, and the things they normally enjoy doing, they don't have any pleasure doing. And then they say that 5 or more of the following, okay? And there's a total of 9. The big things are up above, but they kind of all go together also. And there's the next slide kind of helps also remembering what the criteria is. But depressed mood most of the day, nearly every day, diminished interest and pleasure, or interest or pleasure in all or almost all the activities most of the day, nearly every day. So these are the ones that they look at. Significant weight loss when they weren't dieting, or weight gain or decrease or increase in appetite nearly every day. So they go through all these criteria with them. And we talked about sleep, either sleeping a lot or not sleeping at all. Fatigue, loss of energy. Again, it kind of all goes along with what you would expect from someone who's depressed. Feelings of worthlessness. They just don't feel like they have any worth. Or inappropriate or excessive guilt nearly every day, or worthlessness nearly every day. And it can be delusional, which is a false personal belief, not really based on reality, is what a delusion is. And they continue to believe that delusion even when they're given proof to the contrary, okay, that it's false. Diminished ability to think and concentrate, okay, nearly every day. And recurrent thought of death, okay, not just fear of dying, but we call it suicidal ideation. Okay, you're going to hear that term when you go to the unit. Suicidal ideation are suicide ideas, okay? And anyone who verbalizes suicide ideas, okay, we're going to take some special precautions. And the hospitals are now going through with any admission and asking people this, because, you know, we have always had the stigma of, oh, we just don't ask about that. If we ask about it, they may do it, okay? They may actually do it. That is not true. So we need to be asking if they have any ideas about hurting themselves. Then we want to determine, do they have a plan, okay? We're more concerned if someone is talking, and we'll talk more about suicide, but while I'm hitting on it, we'll go ahead and hit on this, that if they have a plan, we're more concerned, okay? I'm going to, once I go home, I've got a gun and I'm going to shoot myself in the head, okay? That's a plan, okay? So we want to see if they have some sort of plan. Have they ever had an attempt, a suicide attempt before? And do they have means? Okay, so if they've got a gun at home, they've got means. Okay, So we want to determine all those. And of course, we'd never send anyone home if we knew that there were guns in the house, right? So that would be part of the family's role to get all the weapons out of the house if we had a patient going home with suicidal ideation in the past. Okay, so this kind of helps you remember the main signs of depression, and it's SIG-E-CAPS, a little acronym to help you remember. So sleep disturbance is for the S, I, interest decreased in the pleasure activities and sex. Guilty feelings is your G, E, energy decreased, C, concentration decreased, A, decreased or increased appetite, P, psychomotor function. Psychomotor function is, they're just not very active, okay? They move very slowly, want to sleep all day, just really don't want to be that active. And S is suicidal ideations. Okay. How's our time? Oh, let's take a break. Okay. All righty. So do I have any questions? No, I don't see any questions. So let's go ahead and let's see what time it is. Okay, I have 2:03. So come back at 2:15 and we'll get started again.
I sent you a message on here. I just wanted to make sure you got it.
Is this Becca?
Yes, ma'am.
I did, and that's a great idea. You should do that.
Okay, thank you.
Okay. I hope you feel better.
Thank you.
Uh-huh. Okay. Oops. Let me start the recording again. I'm getting better at remembering this. Okay. All right, here we go. All right, let's see, next one. Okay. So if we look at predisposing factors to depression, there is a genetic hereditary factor that can be one of the predisposing factors to depression. So there is a genetic predisposition for that. Also, they've found some biochemical influences, a deficiency in norepinephrine and serotonin have been implicated. And of course, that's the medications we use, right? The medications we use are selective serotonin reuptake inhibitors and norepinephrine reuptake inhibitors. In other words, that makes norepinephrine and serotonin more available because the body is not taking it up. So those are the medications we use. So that goes along with that biochemical influence. And it can be the result of inherited genetic predisposition and environmental factors also. Psychological theory is that the thought is that, what they found is a personal history of being deprived and going through a traumatic experience or having a significant loss, especially in the younger years, can predispose you to depression later on in life. Environmental, when we look at that, low self-esteem and a sense of helplessness because of the environment can definitely cause depression. So whenever someone comes in with signs of depression, I don't know if I'm sharing this. I don't think I'm I'm sharing this. You're not sharing your screen. Okay. Hey, feel free to yell out when I'm not sharing my screen. Okay, let me try this again. Well, wait a minute. I got to hit the share screen. That's what I got to do. There we go. Sorry about that. Feel free to scream out if I do that again. Okay. And I just realized it. Okay. So what did we miss? Let's see. Let's go back here. Would you like me to go back and hit on that one more time? It wouldn't hurt. Okay. Now can everybody see my screen?
Yes.
Thank you. I appreciate that. Okay. So just to reiterate, it can be, they found a genetic predisposition. So family history can predispose you to a higher risk of depression. And then the biochemical influences, again, the norepinephrine and the serotonin. And that's why we use norepinephrine and serotonin reuptake inhibitors. So there's more of that available. And it can be inherited predisposition. And then along with environmental factors can definitely predispose. If you're in an environment that is a struggle with a lot of stressors, that can definitely, with the predisposition that you've inherited along with the environment, can definitely lead to depression. Okay. And definitely, if you've had a personal history of being deprived, I think of childhood or trauma, anytime there's been a trauma, but they have found that a significant loss at a young age can predispose someone to depression also. Okay, now we're good. Okay, whenever someone comes in with signs and symptoms of depression, we want to rule out any physiological issues that could be causing it. It could be a medication side effect that's causing the depression. Of course, our CNS depressants cause depression, they decrease the they are CNS, they depress the CNS. So of course, those, if they're being overused, misused, could cause signs of depression. They've taken Accutane off the market, but the acne medication Accutane was found to be related to causing depression. Steroids, if you've ever been on prednisone for any reason, it can cause fluctuations in your mood, definitely. Either you can be depressed or you can be anxious or you could be irritable. So definitely steroids can do that. And then some antibiotics, especially in the older folks, sometimes that can cause depression. So want to rule those out. Want to rule out any neurological disorders, any brain tumors, Alzheimer's, Parkinson's disease, those type of things can cause depression, definitely. Electrolyte disturbance. If someone has an electrolyte disturbance, they can exhibit signs of depression. So we want to rule that out. Hormones, hypothyroidism. I believe you guys have learned about hypothyroidism. But anyway, hypothyroidism, when the thyroid is not functioning well, those people are very sluggish and, weight gain and no energy. And, so it could be a hormonal thyroid issue. Or it could be estrogen and progesterone. Those fluctuations can also cause depression. Even it could just be a nutritional deficit. B vitamins, C, iron, folic acid can cause signs of depression. And then other ailments like lupus, cardiovascular disease, chronic diseases like diabetes can cause someone to feel depressed too, or cause depression. Okay, so all those need to be ruled out. So, if some of those we can correct, so then that would solve that problem. Okay, so if we look at our psychosocial theories, our guru, Dr. Freud, has the psychoanalytical theory of that someone has internalized a loss and it becomes internalized, and that causes the depression. Basically, that's what this is saying. Or another theory is that it's been learned. It's learned helplessness. So the individual who experienced lots of losses can't win for losing. It just seems like everything goes wrong for them. They just eventually give up. So they just learn, what's the use? Things are never going to get better for me. So learned helplessness does predispose individuals to depression by giving them a feeling of lack of control over their life situations. Then we look at object loss theory, and this is what I was talking about, where there is a loss of a significant other, parent, I think of, during the first 6 months of life. And you think, what does a baby know? But, they have found that if a baby loses their significant other, mother, father, during the first 6 months of life, this can predispose them to depression. Because these folks grow up and they feel helpless and despair. And this early loss or trauma can definitely predispose them to lifelong periods of depression. So it's amazing to me that at such a young age that can have such a impact on their life. So when we look at depression, of course, risk for suicide. Now, when our depressed people come in, typically they don't have a lot of energy. They have thoughts, ideas, suicidal ideations, but they don't have the energy to carry it out. So, but they're still at risk, and we want to watch them very closely when they're very depressed. But what happens, and I know Ms. Hyde hit on this, was when we get those antidepressants kicked in, and we want families to watch them really closely, their family members, for, after a couple weeks, they may be feeling really good and have the energy to go through with the suicide. So that's why all those warnings about watching for suicide, especially after the 2 to 4 weeks before that medication kicks in good. Because, okay, now I can carry through my plan, and they appear to be happy because they've got enough energy to carry through that plan. So got to watch our depressed folks once they start on antidepressants. But they're still at risk even when they're depressed because of feelings of worthlessness, also the anger towards inward. Freud talks about it causes depression, and misinterpretations of the reality. Everything is my cup is half full, or excuse me, half empty. I said that backwards. Woe is me. Things are never going to get better. So very negative perception on everything, even if it's not negative situation. And then they also have a low self-esteem. And this is because of the learned helplessness. Why do I bother? Everything goes wrong. Anything I do, doesn't work out. feelings of abandonment by the significant others, that loss in early years. And it could be that their thinking is impaired, and that gives them the negative view of self. And we'll talk about, some people just get trapped in that negative thinking about themselves. So we need to go in there and re-switch that thought process, which we'll talk about in just a second. So they're not constantly thinking, oh, it's not going to work out. Why should I bother? Another nursing diagnosis is social isolation. They don't feel like being with people. They don't feel like talking to people. And this could be developmental regression, egocentric behaviors, narcissism. They typically think they're awesome. However, it actually occurs because of a low self-esteem or feeling inferior in certain situations. So they overcompensate and act like they think they're all that. But what happens is it's caused by a gap between the ideal self, the standards set by others like parents, and the real self. Okay. So this can happen because of a childhood situation. And definitely all of our egos are influenced by the approval of others. So if they did not have approval of their parents when they were young, then they grow up becoming narcissistic because of that. Fear of rejection or failure, which also causes them to have an impaired social interaction with folks. Fear of rejection or failure of interaction. If they think, I don't even want to go there because I'll mess it up somehow. Okay. So the big thing with our depressed people are we don't want them to hurt themselves. So definitely the goal is no physical harm to self. Another goal is to discuss the loss with staff and family members if it's because of a loss that they've experienced. We want to help them come up with some realistic goals for themselves. We want them to maybe attempt a new activity, but we don't want to set them up for failure. So talk to them about, what they enjoy. Typically try to get them involved in, do you like to draw? We can set them up with some art markers, and they have at the VA, they have these books, those coloring books for adults, which are kind of fun, where they give them markers, because markers are, they can't harm themselves with markers. And then, of course, they're watched while they do it. But those are kind of fun. And some of my students have actually sat down and done those with some of the patients. But that can be very therapeutic, and that's what studies have found, that coloring as an adult is also therapeutic. It's fun as a child, but therapeutic as an adult. And help them to identify if they've had self-control issues. Maybe a better way of helping, have a goal of self-control over certain life situations. How can they control that? So our medical management, or our management of the illness, definitely includes medication management. We'll talk a little more about that. Assertive techniques, because sometimes they have that learned helplessness. They have a low self-esteem. People pick up on that and maybe have taken advantage of them. So we need to teach them how to be assertive, watch out for themselves. Some stress management techniques, definitely. If it's a stressor related situation that's got them depressed, how can they deal with their stress? If they're abusing alcohol to deal with their stress, of course, alcohol is going to make them more depressed. So let's talk about some ways that you can manage your stress in a healthy way. Exercise, walking, find out what they enjoy, and ways to increase their self-esteem, and then electroconvulsive therapy, which we'll talk more about in a couple slides. Definitely, we want to educate the client and the family on their support system, what the suicide hotlines are, support groups, any legal or financial assistance groups or people that we can connect them with. So typically the treatment, can be just medications, but a lot of times it's a combination of medications and psychotherapy approaches. And we have the different ones, individual, cognitive, group, and family. There is a list of antidepressant meds. And of course, you guys got your little list from Ms. Hyde, but on page 411 in the newest book, table 16.3, there's a list of the medications. So individual psychotherapy focuses on addressing the person's past losses, if that's the case, or their stressors, what is causing them to be depressed. Then cognitive therapy is typically short-term, and cognitive therapy is how we help them develop. Well, actually, we don't. The psychologists or the psychiatrists typically would be handling this, psychologists typically, but help them develop new strategies. But of course, we can support it to alter that negative thought process. Okay, so try to change the way they think. They automatically go to, oh, this isn't going to work out. And we want to change it to, I'm going to do this. This is going to be great. Okay, try to change that automatic negative thought process from happening. And a group therapy is good to address if it's a socialization issue. The group peer pressure can not peer pressure, but peer interaction can help them with their socialization and help them with their self-esteem, to build up their self-esteem. Okay. Then family therapy, if the family is promoting or encouraging somehow the depression, or part of the problem is the family, they would be involved in family therapy. Okay. All right. And just a little last note about light. 15 to 25% of people with recurrent depressive disorder exhibit a seasonal pattern. And I think we all can attest to this. I mean, don't we all feel better when the sun's out? But there's people that are affected even more than just us, like, oh, it's such a dreary day, to, oh no, it's a terribly dreary day. But so it's worse in the winter. These folks that have we call it seasonal affective disorder, or SAD, where they get really depressed in the winter because of the lack of our sunny days. So the treatment for that is bright lights. Okay, so that seems to help these folks when they're diagnosed with seasonal affective disorder, to have light therapy for the winter months. Okay. All right. More about the electroconvulsive therapy, or ECT. So ECT is inducing a grand mal generalized seizure through the application of an electrical current to the brain. And I know this sounds kind of hideous and awful and heinous, but it really does work well. I have seen it with patients that we've had at the VA, where what happens is they subject the person to that electrical current through the brain. It's very controlled. It's not barbaric. And it's only can last less than a minute. And they watch for the stimulation in the brain with the electroencephalogram. Okay, shows the triggers, and the doctor will determine, okay, that's good. We saw the little flashes. So this can be done like 6 to 10 times at a time. What they're looking for, like for 4 to 8 weeks, what they're looking for is they want to alleviate all symptoms. When they get to this type of therapy, they want their goal is the person will not have any symptoms of depression. And like I said, I've seen it where I saw a person come in depressed and then saw them outpatient come in for an ECT procedure, an additional one. And it was like, oh my gosh, they're a different person. So it really is very helpful for some folks. And we'll talk about the people that we would have this for, which I'm getting into now. So if someone's very suicidal, and being treated for severe depression, they're a candidate for this. But what we don't give this to all our depressed folks, right? It's just the severe depressed folks where antidepressants have not helped. Okay. So this is solely for people that are not getting help or not getting relief from their depression with medications, okay? Or they're so suicidal that we can't wait for the medications to kick in. The exact mechanism of the ECT are not fully known, but there's some theories. And the doctor I spoke with who had been giving the ECT therapy believes that the next theory is that it helps increase circulating several of the neurotransmitters. So serotonin and norepinephrine, it tends to increase the circulating serotonin and norepinephrine. And he believes that is the case, that's how it works. But that is just a theory. Side effects, you do need to remember the side effects are temporary memory loss and confusion. Big things. So don't make any legal decisions for a certain amount of time, depending on your facility, whatever they say. Definitely not for the first couple days. Don't make any, legal changes, anything important like that. Because there can be temporary memory loss and confusion. Also headache, nausea, and muscle aches, okay? Some folks I've talked to said that they still have a little memory loss, but ideally it's just temporary, okay? These folks before the treatment are NPO after midnight. Of course, there's informed consent. They have to agree to do this. We have them void before they go down for the procedure. They're typically given a muscle relaxant just to prevent fractures because of the seizure, and a sedative, and maybe even atropine, which dries up the secretions in the mouth. They will definitely do this where they have oxygen available and suction available. And definitely after the procedure, they'll be monitoring vital signs, orienting the client, and looking to see, so they're assessing their affect and mood before the procedure, and then they're definitely, monitoring and assessing for their mood and affect after the treatment. And, could be a sudden improvement, or also thoughts of suicide because they're feeling better. Again, just like our medications do, this may make them feel better enough that they might have more suicidal thoughts. So some of my students have got to see this. And so hopefully, I'm not sure again, I didn't ask the instructor that typically goes to LifeWorks whether they've got to see ECTs. I don't believe they do those at LifeWorks, but we'll find out. It would be really neat if we could see that, if some of you could go to that. Another more modern form of the same thing is TMS, or transcranial magnetic stimulation. And they were not doing this at the VA the last time I had students there. But what this does is uses magnetic pulses instead of electricity to stimulate the brain. So I know Ms. Hyde's talked about the different medications, the different classifications of antidepressants. All of them, the tricyclics, the SSRIs, the MAOIs, the heterocyclics, and the SNRIs, all require some time to kick in before improvement's seen. So definitely severely depressed people need to be monitored again. I've said this. When their mood begins to lift, when they start to feel better and they have increased energy, that, there's no thoughts of suicide. They're not setting up a suicide plan. And so we'll be assessing them for any suicidal ideations. So this is a little slide that kind of tries to help you remember some of the tricyclic antidepressants and their side effects. Those are a few of them at the top: amitriptyline, Elavil, doxepin, Senequan, nortriptyline, Pamelor, and imipramine, tofranil. And let's see what it says here. Watch for sedation. Orthostatic hypotension is a big one to know about that. Dry mouth, urinary retention, tachycardia. Okay. And I'm sure Ms. Hyde already mentioned to you that our number one line of defense is our SSRIs. Why? Because they have the least side effects. Okay, so typically you won't see too many of these other antidepressants unless, the doctor is trying something different because they're still struggling with depression. But definitely our SSRIs are our go-to to start with. And here's a little acronym to remember: our MAO inhibitors, Nardil, Parnate, and Marplan. No popular meds, to remember those three. Never want to take any barbiturates with these. Don't want to mix tricyclic antidepressants with these, or antihistamines, or CNS depressants, antihypertensives, or over-the-counter cold meds. Also, that's my thought. Tyramines. It wouldn't come to me for some reason. Definitely, you have to avoid tyramines with these medications. So again, there's a lot of people that can't take these medications because of the potential side effects and with other medications and some foods. Okay. Signs of that are sweating, tremors, dizziness, increased blood pressure. Our cheeses, our wine, our pickle foods are big ones, and also pounding heart rate. You will need to know about that, definitely. And of course, Ms. Hyde is, coming up with the medication ones. So I'm sure she gave you some insight on what you need to focus on. So all of our tricyclic antidepressants, our heterocyclics, our SSRIs, SNRIs, all block the reuptake of the neurotransmitters, norepinephrine, serotonin, and or dopamine. Our MAOIs, just, I know I'm rehashing what Ms. Hyde said, but it never hurts to hear it again, does it? Inhibit the monoamine oxidase, which is an enzyme which inactivates those neurotransmitters, norepinephrine, serotonin, dopamine. So if we inhibit that enzyme, of course, then our neurotransmitters, norepinephrine, serotonin, dopamine will be more readily available. So that's how those work. So just a little question, when teaching about the tricyclic group of antidepressant medications, which information should the nurse include? Anybody want to yell out the answer?
B.
B, very good. A client needs to be advised, B is the answer, a client needs to be advised that it may take several weeks, as it does with all of them, for tricyclic medications to reach their full therapeutic effect and for relief of symptoms to be noted. Some continuation of the pharmacology is the client and family education related to antidepressants. We definitely want to educate them that it could take up to 4 weeks for the symptoms to get better of depression. Don't ever discontinue any of them abruptly. They should, if they are to be discontinued, it should be with physician's assistant and gradually decreased over time. Avoiding smoking and drinking alcohol with these, and be aware of the risk of taking antidepressants during pregnancy, which the doctor will be on top of. Here's a list of some other medications with tyramine, not to eat or drink with MAOIs. The aged cheese, the wine, fermented stuff, processed stuff, yeast products, pickled stuff, soy sauce. Those are the big ones. But there's a couple other ones there. Okay. Question. A client has been diagnosed with major depression. The psychiatrist prescribes paroxetine or Paxil. Which of the following medication information should the nurse include in discharge teaching? Anybody can yell it out.
C.
Yes. Again, you don't want to discontinue any of the antidepressants. But this is an SSRI and should not be stopped abruptly. And they all have varying potential of causing discontinuation syndromes or side effects. So, but the ones with our SSRIs are typically dizziness, lethargy, headache, and nausea.
Mm-hmm.
Somebody's microphone isn't muted, which you're not saying anything bad, but just to let you know. Okay. So nursing interventions, helping with them formulate some small achievable goals, always encouraging them to talk about their feelings and concerns. And as students, you're great people to practice your therapeutic communication with them, to let them talk about their feelings and concerns. And what you'll find is, they'll typically lead the conversation. A lot of my students say, they get, how are you feeling today? Which is a great broad opening statement. Or do you have any concerns today? Well, that's kind of a yes, no, feelings and concerns. How are you feeling? Or would you like to talk about how you're feeling today and any concerns you have? Of course, that's yes, no too. Not coming up with a therapeutic way of saying that. But anyway, how are you feeling today is a good broad opening statement. And what was I going to say? Oh, a lot of my students say, after that, they just use silence, just let the person talk. A lot of times that's all they need. That's all they want. And they really, really appreciate just having someone listen to them, let them talk. Of course, we want to encourage independence because when they come in, they are so depressed that they're pretty dependent on us to help them with most things because they just don't have the energy or the ambition to do them themselves. So gradually we want to, promote them to be more independent. Definitely physical activity, encourage physical activity. It definitely promotes a sense of well-being, but also gives them less time to ruminate, go over and over negative thoughts. Okay. So gets them out of just thinking about negative things. Physical activity is good for that. Self-esteem, encourage to challenge the negative thoughts. I don't believe that to be true, or some sort of comment like that. And try to help them come up with some alternative solutions to a problem, or always, and always be the cheerleader. Oh, you did great with that. I can tell. How are you feeling today? You appear to look like you feel much better today. Those kinds of things. Okay. And then if we look at our elderly, just to mention this, some elderly patients, I think when we look at the elderly, which we'll be talking about dementia and Alzheimer's, and, typically we think, oh, they're older, they're getting dementia, they're getting Alzheimer's. So they can be frequently misdiagnosed because simply they're in the older age group. And they can come in, older folks can come in with confusion and social withdrawal and be misdiagnosed. So how do we diagnose someone older with depression? We go through the criteria, just like we do with all our patients, okay? But a lot of times they're misdiagnosed, which is sad to think, with dementia, where it's truly depression. Definitely, we're always, exhibiting a calm, accepting attitude with all our patients. And, touch is typically good and okay with our depressed patients. Definitely not with our psychotic patients that have delusions and hallucinations and, inappropriate thoughts of reality. But our depressed patients, typically are good with some touch, but we'll just have to figure that out. And even if you just sit, again, calmly with them, and if they don't even feel like talking, just sitting with them can be very therapeutic for them, just sitting in silence. And, we can, as nurses, as students, I think you can also reassure them that it's, this depression is going to get better. Typically, it usually, I guess we should say, usually, it gets better once you start on the medications. It just takes some time. Of course, we don't want to give false reassurance, but, give them reassurance that it's going to get better. The medication just has to have time to kick in. And these folks, you don't want to, come in with this cheery, over happy, life is wonderful attitude and pep talks. You can do this, you can get better. No, they need that medication to kick in for them to get better. But of course, if you notice some improvement, you definitely want to point that out to them and, say, I can tell, you look like you feel better. Do you feel better today? And, have them talk about, tell me how you're feeling. And definitely, giving them some tasks to complete, of course, that they can be successful in is always good. Definitely, we take care of their physical needs, especially when they first come in and they're severely depressed. So we're going to promote eating. They might not feel like eating a whole meal, so maybe some small frequent meals. Find out what their favorite foods are. And then, just sitting with them, offer to sit with them while they eat, can, make the eating process more enjoyable so that they'll eat more. Definitely, they need to get rest. Sometimes we have to motivate them to get out of their room, get out of their bed, but they definitely need rest periods also. And definitely provide a quiet sleeping arrangement. When you go to the psych unit, they'll always talk about how much sleep they've gotten. They'll say 8 hours uninterrupted or 6 hours interrupted, which means uninterrupted means they slept for 8 hours straight. That's a good sign that they're feeling better. They're sleeping well. Because if they're sleeping well, they're typically feeling better. But if they say like 4 hours broken, anticipate that person not sleeping, not being very perky the next day, and that they're still in the acute phase of their disorder, waiting for those medications to kick in. But definitely, they usually have something ordered to help them sleep if they have problems with insomnia, so they can sleep at night and be up during the day. And always with medications on the psych ward, you're always making sure that patient swallows their med. What can happen if, they pocket it under their tongue, in the side of their cheek, they're saving it up possibly to take them all at once and overdose. So on a psych ward, you always watch the patient. Well, I would say you pretty consistently do. I guess it depends on your facility, what your policy is, and what you think the risk is of that patient saving up their pills. But typically it's a good idea to have them open their mouth and lift up their tongue. So we make sure that they're not saving those pills up. Okay. So this is a good time for a break before we start suicide. Let me see if I have any questions. Okay. All righty. So I'm going to and we're next going to talk about suicide. Well, hang on. Moving. Well, let me try this one. Okay. There we go. There we go. Okay. Can everybody see I'm recording, right? I think I hit it.
Yes, it's on recording.
Thank you. I appreciate that. Okay, suicide. So most suicides are associated with mood disorders, depressive disorders account for about 80% of the suicides that occur. When we look at demographics, The highest age range is 45 to 64 years of age. However, adolescents and elderly are at a high risk also. Gender, males tend to commit suicide more so than females. If we look at ethnicity, Caucasians are higher than Native Americans, who are higher than African Americans. Marital status, again, single, divorced, and widowed are higher than married. So marriage protects us also against suicide. Socioeconomic, individuals in the highest and lowest of the socioeconomic classes are higher than middle class. So actually being middle class, you're less likely to commit suicide. Occupation, professional healthcare personnel, that's us. So take care of yourself, guys. And business executives are highest. I'd be interested to see how this COVID-19 is affecting those rates. I know from what you see on TV, what I've seen on TV, you know, and those of you who are working in the hospital right now, it's very, very trying time. And, you know, it wouldn't surprise me if suicide rates were higher now in healthcare personnel, but definitely it's important to have time for yourself, take care of yourself, and we'll talk more about that later. But method, firearms are higher than overdoses, and I've heard that men typically use firearms, women typically will overdose because women don't want to make a mess. That could just be a myth, but that's what I have heard. Definitely, if someone wants to kill themselves, a firearm is definitely going to get the job done. Where an overdose, someone may come in time to rescue them. Religion, there's really no religious connection, affiliation where one religion is higher than the other. Family history, if there is a family history, that does put the relatives of the family member at higher risk for committing suicide. So when we have these folks come in, we're definitely assessing them for any psychiatric or physical conditions when they come in, any history of any substance use disorder, and how serious is their intent? Do they have, as I said earlier, do they have a plan? Do they have a means? Have they had a previous attempt? Are their behaviors, and we'll talk about behavior cues in a couple slides, clues that, you know, behavior that would make us suspicious of them wanting to commit suicide, and then just verbally some clues that they can give. Do they have a support system? Remember, that's one of our attributes that support a healthy mental health, mental health, I should just say. It's important for mental health. So do they have a support system? Any precipitating stressors, the death of a spouse definitely can precipitate depression, loss of a job, maybe both. If we look at our elderly, which we'll talk more about, but I think of all the losses that they go through. And so they're definitely at risk for depression. You know, they may have lost their spouse who had taken care of them, and then they have to move to the long-term care facility. So they've lost their house and they've lost their friends in the neighborhood. So it can be, you know, a lot of those factors can play a role in depression. And any thoughts, any suicidal ideations that they may have. So some clues of impending suicide. If someone, there's just a sudden change in their behavior, as we talked about, if they become more energetic after a period of severe depression, be suspicious that they have a plan, and talk to them about it. If their mood's improved in about 10 to 14 days after starting antidepressant, that's a high risk time. Could indicate that they have a suicide plan. If they are finalizing business and personal affairs, if they're giving away their personal possessions or pets, these are all clues that they might be considering suicide. If they withdraw from social activities and plans, they make the statement, well, don't worry about me for Christmas, or you won't have to worry about me during Christmas, those kinds of statements. They appear emotionally upset, definitely. Any weapons, razors, pills, means. Those are means. We want to make sure that they don't have those. If they've had any history of suicide or suicidal thoughts, ideation. They have a death plan. They leave a note, which typically is a little bit late in the process. Or, like I'd said earlier, makes a direct or indirect statements. I may not be around then, so don't worry about me. Don't make your plans around me. I might not be around then. Those are red flags that we should take very seriously. Definitely, the person should not be left alone if there's any clues of suicidal thoughts. So anytime in the hospital, someone would make a comment that, kind of was a clue that they might be considering that, they would be put one-on-one. But if they're at home, they should not be left alone. Actually, establishing a no suicide contract is done frequently on the psychiatric ward and works pretty effectively, where the person contracts, I will not commit suicide for the next 30 days. Okay. And you would think that wouldn't hold much weight, but it actually is used pretty frequently. So, putting it in writing does tend to help. Definitely, we're always assessing the environment for safety. And like I said, if you ever have a psychiatric patient or you have a patient on the medical surgical floor, because they have medical surgical issues, which we'll talk more about in 212. But anyway, you want to always make sure that the environment's safe. And, that's the scary part, is the unit's not designed for psychiatric patients. So, there can be a lot of hazards that we wouldn't normally think of as hazards. Definitely giving them antidepressants and anti-anxiety medications is definitely part of the plan of care. Good therapeutic communication, good listening, and allowing them to verbalize their feelings. Definitely also giving clear explanations and be, sincere, convey a sincerity that you're there to help them. What can we do to help? Definitely remain non-judgmental and give them community resources. Okay. And, be watching for more suicidal ideation when it appears that the depression is lifting, right? Okay. Goals: the client will not harm himself during this hospitalization is a good goal. The client will seek out hospital staff when ideas of suicide occur. So if you're ever feeling, like you want to commit suicide, please come and talk to me, okay? Because verbalizing their feelings can definitely help with that. And the client will maintain a short-term contract not to harm themselves by a certain date. And then we have the suicide prevention online resources that we definitely want to make available to the patients and family members. And those are 4 of them. Okay, any questions about that? All right, so we have about 20 minutes. So let's go ahead and get started on bipolar. I just want to allow enough time for all of our stuff. So we'll go ahead and pick up on that next. Pause this a minute. Okay, so let's start the recording. Get too excited and don't hit share my screen. Okay, there we go. Okay. So bipolar disorders or disorder was previously known as manic depression. It is a mood disorder where individuals experience extreme cycles of mood, depression, or euphoria. Some of the terms: hypomania. So hypomania is a mild form of mania, and it lasts about at least 4 days to be diagnosed with hypomania. And it's associated with hyperactivity, but not severe enough to cause marked impairment in social or occupational functioning, also known as a hypomanic episode. So these folks are able to function in everyday life and just seem like they've got a lot of energy. Hang on, I got to plug in my computer. I forgot to plug it in. There we go. That lit it up more. I wonder why it wasn't as bright as it normally is. Excuse me. Okay. Okay, so this is hypomania. Then we have mania, which is definitely a predominant mood elevation, very expansive, can be these folks can be irritable, lots of motor activity. They're constantly moving, and also called a manic episode. These can last from a few days to several months. So you can imagine how drained these folks are after several months of this. Then another term is mixed features. And these are where the person has both symptoms of alternating moods between slight euphoria and depression. However, oh, pardon me, I'm thinking of something else. I'm sorry. So this is where they rapidly alternate moods, okay, where they're sad, irritable, or euphoric, or depression. Okay, so they have symptoms of both, which makes sense, mixed both depression and mania. Okay. Three different types. That's what I was thinking of, cyclothymic. So mixed is combination of both. Bipolar 1 is where an individual presents with manic episode. Okay, they have mania. And they have a history of one or more manic episodes, okay, to be diagnosed with bipolar 1. And may, as you see, if you see my notes, it's bolded, okay? They may have experienced episode of depression, okay, but not necessarily may, okay? And they can have psychotic or catatonic features also, okay? Psychotic, we talked about. Catatonic, just not, no kind of a blunted affect, okay? Bipolar 2, on the other hand, is mostly depression, okay? But they can give a history of an occurrence of hypomania, not mania, but hypomania. This person has never experienced a full episode of mania, okay? So 1 is predominantly manic, okay, with may have had a history of depression. Bipolar 2 is predominantly depression with at least one episode of hypomania, okay? Cyclothymic is characterized by chronic mood disturbance of at least 2 years. So that's one of the criteria. And it involves numerous episodes of elevated mood or depression, but the elevated mood is not even enough to meet the criteria for hypomania. So they have an elevated mood, but not hypomania. And remember, hypomania is less than mania. Okay, so just an elevated mood, and have episodes of depressed mood, however, never severe enough to meet the criteria for major depressive disorder, okay, or episode. So the person is, for 2 years, is never without symptoms for more than 2 months, is all the criteria on that. There is the DSM-5 criteria on page 424, box 17.3 in the new book. Okay. Causes of bipolar disorder can be, it's thought to be a chemical imbalance in the brain. And what they have found is with the depressive symptoms, bipolar 2, they have a deficit of norepinephrine and dopamine. Individuals with mania symptoms have an excess of norepinephrine and dopamine, okay? However, in both cases, both the depressive and the manic, they both have a low serotonin level, okay? There is a genetic predisposition to this. Looking at twin studies, they have found a vulnerability to genetic predisposition for bipolar disorder. The strongest evidence shows that it's a combination of a genetic predisposition and environmental triggers. Okay, so they've got the predisposition that they've inherited, then they're faced with environmental stressor, life event, and that triggers them to exhibit the bipolar disorder. We always want to, we always want to rule out medical issues before we diagnose, but what I want to say here is some medical conditions and medications can actually cause bipolar disorder to manifest itself in a person that has predisposition for it, and maybe environmental triggers. But certain medications can also trigger this to happen. Again, steroids. Of course, we never want to use steroids without our doctors prescribing them. But some people abuse steroids, and that can trigger in someone who's got the predisposition for bipolar disorder in their family to develop bipolar disorder. So that's a good reason never to abuse steroids, right? Hyperthyroidism. Okay, so hypothyroidism, remember we talked about, can look like depression, and actually be hypothyroidism. But hyperthyroidism can actually trigger someone to go into bipolar disorder. Abuse of amphetamines, and there's some other things that can cause. So medical conditions and certain medications can cause someone to develop bipolar disorder. Some facts about bipolar disorder. It's the 6th leading cause of disability in middle-age group. It affects males and females approximately at the same rate, equally. Episodes may or may not be associated with periods of depression. Remember I said bipolar 1 manifests itself as mania, but they may have had a history of previous experience with depression, okay, but not necessarily. So they may or may not have depression, okay. Usually it's initially diagnosed between the ages of 15 and 24, with the average age of onset in the early 20s. So if we look at what's happening in the early 20s, these are where our kids are going off to college or starting their career. They're, maybe moving out of the house and having all the stressors of maintaining their own home. So this can be, if you've got that genetic predisposition and the stressors of what happens in our 20s, that could definitely cause bipolar disorder to surface. Definitely after the first episode, there is a high risk of it reoccurring. Some people have periodic episodes where they're separated by years, and others have much more frequent cycles of bipolar disorder. As is with depression, it's more common in our unmarried than our married. This, again, marriage protects us here too. However, unlike depression, it occurs more frequently in the higher socioeconomic classes. They are more in touch with reality. They have less psychotic issues, features than schizophrenia. As I said, if I had to pick out one, that would be the worst mental illness that I can think of, that I would say that about schizophrenia, that it is the worst, the most debilitating. These folks can be very manipulative, so you have to watch them because they will try to manipulate you. They'll try to manipulate the staff, play one against the other. So you got to watch them for that. So the symptoms, of course, the manic phase, and this may last from days to months, cause a very marked disruption. Of course, any disorders cause disruption in the person's life where they can't function, do their day-to-day occupation, go to school, these kinds of things when they're having an episode, okay? But it does cause disruption of their occupation, their social functioning, and can have psychotic features. So our psychotic features, again, are our delusions. They can be very common. They may think that, and we'll talk more about the signs and symptoms. They grandiose. They think they are really somebody special. They think they're great, and a lot of times the problem is they don't think they have any problems, and they love all their energy, and they think they are, they are set, they are the best. So they'll stop taking their medications because of the side effects of the medications. And that's when they get into trouble and end up coming back in to see us on the psych ward. So during a manic phase, at first they might be, a little hyperactive, getting a lot of things done. But as it continues, it starts to affect their day-to-day occupations and social functioning. But like I said, psychotic features, they could actually have hallucinations also. And their self-awareness is not usually good. Like I said, they don't think they have a problem. They think everything's great. They think they've got it all together. So that's where the problem with treating these folks is. The depressed phase consists of symptoms very similar to major depressive disorder. But again, they've had at least one episode of hypomania. Okay. Not mania, but hypomania. So they also have, may have delusions, are definitely possible, abnormal thoughts, that are congruent with reality. Okay. So our manic symptoms, they're very elevated mood, very involved, active, very hyperactive, lots of energy. They have racing thoughts and ideas and talking a lot. So they can actually be very trying to the other patients on the unit because they're talking a lot, nonstop, and have lots of ideas and racing around and, maybe jumping on the table and, those kinds of things. So we got to watch them for safety issues. Okay. Very easily distracted, definitely. Or they have false beliefs about themselves. Okay. They grandiose thoughts. They think they're really something special, and their abilities. So yeah, they might try to do a cartwheel in the middle of the floor and, hurt themselves. So safety is a big issue with these guys. And sometimes it's kind of hard to not laugh at them, but definitely you can't laugh at them, because if you laugh at them, you're going to just egg it on. Oh, they love that attention. So yeah, but they can be pretty hilarious to watch, but very draining to take care of all day. Another thing is they don't need any sleep. Okay. So again, in report, if we hear someone's came admitted with bipolar mania, and they've slept 2 hours interrupted, you know that they're in a very acute manic phase for sure, because they can't sleep. They feel rested, like after 3 hours of sleep. They can be temperamental, so they're irritable and easily agitated. So again, that can be a problem on the units. They tend to be very reckless with their behavior and lack self-control. So, they may be over drinking and using drugs or binge eating, very poor judgment, promiscuous behavior, spending sprees. If they get a credit card, they're going to go shopping and charge out the wazoo till the credit limits hit. Also, in the early phases, well, let me just say it, in the early phase, it seems like the individuals, life of the party, very engaging, outgoing, high achievement. If they're working, they're getting a lot of stuff done. But as the mania accelerates, that's when they become more frenzied and out of control, and make poor decisions and possibly hazardous actions on their part. Okay, and again, this can last for a few days to several months, so you can imagine how exhausted they are when it's all said and done. Okay, I have one more page and then we'll be done. Sorry. The DSM-5 states 3 or more of these symptoms may be present, and that is on page 422. They have an inflated self-esteem, grandiosity, unrealistic sense of superiority. Okay, they think they're superior over others. Talked about the decreased need for sleep. Excuse me. Talked about the flights of idea. And they only have to meet 3 or more of these. Okay, distracted, can be very goal directed in their activity, or non-goal directed activity. And they get in people's faces. Again, this is a problem with these folks on the unit. Okay, they definitely have impairment in their social and occupational functioning and require hospitalization to prevent harm to themselves or others, or someone harming them, actually. Let's see. Okay, the delusions, false beliefs, what is taking place and who they are, or hallucinations. They can also have seeing and hearing things that aren't there. You definitely want to rule out that the episode is not from a substance, drug abuse. And a lot of these folks do self-medicate with street medications. With our bipolar manic patients, they're just poor judgment. But others try to self-medicate to make themselves feel better. They stop their ordered medication and then they use street drugs, and it gets them into trouble. So we want to make sure, but when we're looking at these folks, we want to make sure it's not related to medication or drug abuse. That it's not related to something. So if someone has been treated for depression, here's where this, might be misdiagnosed, comes in, and they're given antidepressants or have ECT, and they emerge into a manic episode, then they've been misdiagnosed. They're not depressed. They have bipolar disorder 1, okay? Because they've gone into mania. Okay, so sometimes these folks are misdiagnosed, either bipolar 1 or 2. It could happen with, actually. Other quick symptoms, I don't want to hold you up, guys. Inappropriately dressed, okay, lots of makeup, lots of jewelry. The next slide is a great one, okay, that just kind of captures, the manic side and the depressive side in a good way. The manic folks joke and dance, and they're hyperactive and put on lots of makeup, and their clothing is mismatched or inappropriate. They just can't stop moving, and they can't stop moving to even eat. So one of the interventions is that we'll give them finger food that they can eat on the run until their medication kicks in and their mania slows down. Very happy, festive, or angry or hostile. Weight loss is common, and they don't have an appetite. They're just hyper, don't want to take time to eat. Insomnia, we talked about, manipulative, due to poor self-esteem, demanding behavior, can be disoriented or incoherent. Talked about the drugs and alcohol involved. Don't meet or unable to meet their physical needs because they can't stop long enough to meet their physical needs. Disruptive, intrusive. Again, this is the problem with even the outside world and on the unit. Gets them into trouble. And they deny. Remember, they think they're fine. And superficial social relationships. Okay, well, I will stop there. And then we'll pick up with the medical treatment. Depressive side of it is basically, again, just like major depressive disorder, except they have had a history of at least one hypomania episode. All righty. Any questions? Okie doke.